and welcome. This is Health and Wellbeing, and I am Lois Appasambu. When we go for medical imaging, which we call scanning, we just expect that it is done for diagnosis and nothing more. However, there is more to radiology and scanning than just diagnosis. Well, today on the program, we will be discussing interventional radiology and how it can be used for treatments as well. Joining me today on the program is Dr. Ohikohai Wellington, who is the chairman of the Association of Radiologists in Nigeria, FCT, and the second vice president of the Association of Radiologists in Nigeria, National. He is a consultant radiologist at the Wuse District Hospital. Dr. Wellington, you're welcome.
You're welcome. Thank you very much.
Thank you very much for joining us on the program.
I'm glad to be here.
Same here. Well, we're going to go on a short break, and when we return, our discussion will commence. Do stay with us.
Following the sudden outbreak of cholera in some parts of the Federal Capital Territory, significant number of cases have been tested positive for cholera. The Health and Human Services Secretariat has intensified surveillance in the affected communities around the area council. Therefore, residents are requested to report any case of diarrhea to the nearest health facility or the Department of Public Health on the following numbers: Dr. Sadiq Abdurrahman, 0803-705-1784, or Dr. Doris John, 0803-315-6560. Ensure that the water used for domestic purpose is clean, boiled and filtered. Start ORS immediately you have diarrhea. Ensure that all food is properly cleaned and well cooked before consumption. Ensure that fecal waste are hygienically disposed of. Do not defecate in the open or into streams. Houses with surface wells should make sure they are covered all the time. Public Health Department, FCT Health and Human Services Secretariat. Announcer.
Welcome back, and thank you for staying with us on the program Health and Wellbeing. Now, before we went on the break, I told you we will be discussing interventional radiology and how it can be used for the care of the patient. And I told you that we're here with Dr. Ohikohai Wellington, who is the chairman of the Association of Radiologists in Nigeria, FCT, and the second vice president of the Association of Radiologists in Nigeria, National. So, Dr. Wellington, going straight to our discussion, what is interventional radiology? I know we've most times heard radiology, but adding interventional to it makes it look like it's a whole different dimension. So what is interventional radiology?
Thank you, Lois. Brilliant question. Following the discovery of X-ray, a whole new dimension of medical practice opened up. Now, so we began to develop systems to use the X-ray to treat people, to find out what's wrong with people, which is diagnostic. What is wrong with you? We use the various modalities in X-rays to find out, from ultrasound to plain X-ray to mammography, CT scan, MRI, and all the gamut of gadgets that are available to us. Now, as that developed, when I went into not just finding out what is wrong, but try to intervene. So radiology now developed into intervening in what the problem was. So we now have what is called an interventional aspect of radiological practice. So that's why we have intervention radiologists.
Now, so tell us more on how this is used now in intervening in issues when people are diagnosed with certain issues or certain problems.
It's also a very wide area, but let's start from the basics so we can communicate. Let's start with ultrasound, for example. Women can come with cysts. Many times, if the cysts are big enough, surgery is to be, or it's still the commonest thing, that the option that they have. But it is very possible to do a drainage of that cyst, and by being guided using an ultrasound scan. So we use an ultrasound scan to locate the cyst. We introduce a needle under proper condition to locate that cyst. Now the ultrasound guides you You go inside there, and you can just, what's the best word for you? Drain that cyst. That's one. When women bleed excessively, for example, you can use methods in radiology to look for the artery from where the blood that is supplying that blood that's coming out, and then block it off. A process that is called embolization. In other words, you put something there to block
it.
that bleeding from coming out. You understand? There are also occasions when the body by its own self goes to block a vessel that blood is passing through to very, very vital organs of the body. Commonly the brain, the heart. You understand? So usually it's a clot, a blood clot. You know, when you have an injury over time, the blood gathers, becomes dry. That's a clot. That kind of clot can form within a vessel that is supplying blood to either the brain or to the heart. So whereas in the first case, the woman is bleeding, you go there to try and block the bleeding. In this case, blood is not getting to the brain. So you're going to try to break down that cloth inside that place. That is called thrombolysis. So you're bringing the thrombus, you're melting it out of the place. So you can now create a passage to the place. There are occasions where people have, for example, new growth, neoplasms, they use the word cancers or something, in some organs that are accessible. Let's say, for example, the liver. And then you can do an ablation. In other words, these areas where the cancers are, you have done an ultrasound, you have done a CT scan or an MRI, you've located the areas. You can, by these imaging processes, directly locate where those cancer cells are to introduce substances that can burn off those cancer cells. Do you understand? So that's a process of ablation, A-B-L-A-T-I-O-N. You understand? So it's a whole gamut of procedures that can be done via the process of interventional radiology. You also find, for example, stones in the kidney. Do you understand?
Yeah, kidney stones.
Okay. That you can also use interventional radiology to intervene. Occasionally, there are blood vessels. It is not a clot blocking it, but by itself, it is just narrowing. Do you understand?
Okay, so the passage is narrowing. And
passage is narrowing. Flow of blood to the place becomes compromised. Function of that organ becomes reduced. So by several methods of radiological procedures, you can try and pass something, let me call it a basket. Do you understand?
Yes.
That you can just live in that place. It doesn't collapse. It keeps the vessel open. So these are a few of the various procedures that we can do using interventional.
So what's the advantage of interventional radiology to surgery? So you gave an example of, take for example, someone that has a cyst, so instead of going under the knife to be cut and then taken out, you just drain it. What is the advantage over surgeries?
Okay. Now, it's not far-fetched. Surgery comes with anesthesia. You don't want the patient to feel pain, so you're going to put the patient to bed, isn't it? So it's going to take the patient a longer time in the hospital. Stay in the hospital will be longer. You understand? where we have a system where the population is huge, the bed space of few, you want people to spend less time on a hospital bed and getting good management. So it reduces the amount of time that people spend in a hospital. Do you understand? Now, cosmetic is another thing. Scar is not there. You understand? So the people don't say, okay, I've done one operation, I'm going to do another. Do you understand? So you can just simply drain it. You can do it as a day case, like I have said. Stay in hospital is a short time. So the people come in, do the procedure, and then you observe them, and they go away. You understand? So they don't have to also suffer from the complication of the anesthesia itself. You understand? So the surgery itself comes with its own complication. The anesthesia to do the surgery comes with its own complication. All these are avoided. Stay in hospital is reduced. So the advantages are actually more than I can tell you.
Does it also reduce the pain? Because, you know, one of the things that...
definitely. Although, in surgery, they're going to put you to sleep, or these days, they may not put you to sleep. They may just give you something. You'll be awake, but in that area. It's also what we do, because you also numb the pain in the places where you're going to pass the needle through. So I think that the pain is also minimized.
Well, you said something about, and that most times has to do with cancer, cancerous cells, and what we lay people call radiation. So if someone has cancer, and then there's a radiation that we call it, where, yes, you go for radiation where it burns the cancerous cells. And I've had people, more than one, more than two, saying, when it comes to cancer, radiation even kills you faster than the cancer. And so many people have said they're not going to go for radiation because it just seems like it's so worse. It makes you so bad. It makes the situation so worse than it actually is. So I'd like you to clarify more for us on that, especially when it comes to people that have to deal with cancer.
Well, radiation remains one of the mainstay of the management of cancer. You understand? One. Surgery, chemotherapy, radiotherapy. Now, we're now saying if you can localize the mass in the place, rather than exposing a larger area to this radiation, you can pinpoint directly to where this cancer cell is, and then introduce the substance that you want to use in the radiation. That be as it may, radiation does come with its side effects. But the issue there is, would you rather leave the cancer rather than having radiation? And you also have to ask yourself, have we had people who have had the radiation who survived the cancer? It's not so hard for people to create an axiom and then start to run with it. Radiation kills you faster than cancer. Radiation, do you understand? And people just keep running with it. But it's very untrue. You understand? The people who have passed from cancer are not from radiation. They are most likely, in most cases, people in whom the disease has been present for a long time, has actually spread from the initial place where it started from to other places in the body. So why you say this woman has a breast cancer, if it is moved from the breast to the kidney and you're irradiating the breast, it's going to be doing the damage
to the kidney as
to
well.
the kidney also, which is also another organ of the body. So you're going to say, oh, this cancer. If it's gone to the bones, it's going to do the damage to the bones. So the problem isn't really about the radiation. It is about early detection. You understand? It is about early detection. And so let's not just keep thinking or keep running around with phrases that are sweet to the ear, but They're
not
not correct.
necessarily true.
Yeah,
True, because that has been something I have heard someone say, like, if I have someone or I have the opportunity to meet someone that is down with cancer and is advised to go for radiation, I would not advise the person. And I'm like, why? And they give all these examples, but because so many people are not as enlightened about it, you know, it becomes something that people run with. And funny enough, people run with things that they get or they hear from people that are not professionals. Rather than from the professionals, they tend to believe, they say, it's from experience. So I know whatever it is, or who this person, I know this person that has had this and has had to deal with all of this. But it's good that you're here to actually help to enlighten people more about it. And so that we understand that it's better that we detect earlier and faster. It would go a long way in helping save the situation as well. Now, talking about radiology, I'd like us to talk about radiology in Nigeria. How would you rate the practice in the country so far?
Well, we are not where we used to be, but the road is still very far for us. That's a simple truth. You understand? There is still a lot of ground to cover in radiological practice in Nigeria. And in fact, personally, I judge the healthcare of any environment by the level of development of the radiological practice. You understand? So when you look generally at our healthcare institutions, we're not where we can be. I mean, we can be in that place, but we are not there at all. And there's still a lot of ground to cover. There's a lot of work to do. We're not where we can be.
So let's talk about what do we need to do to make sure that, now you're talking about the interventional radiology, and people are hearing things that they've never heard. Some people never knew that if they had prostrate, there could be, instead of having to go under the knife, or if you had a cyst, having to go under the knife, there's something that would have been done that would have been made it easier or less cumbersome. And people don't know about it, you know, basically because, like you said, there is a long way for us to go. But what can be done to make sure that we're on track and moving at fast speed to where we should be?
First, I'd like to say one of the biggest things we need to do is belief. I don't know how it happened, but we generally have a mentality of not trusting ourselves, of not trusting our own, of not believing ourselves. You know, some of the things I'm saying, even though I say that there's still a lot of ground to cover, there are pockets of institutions in the country where these services are available. There are few individuals that are highly trained and are experts in the area that are doing these things. So what we need to do first, for most of our problems, is self-belief and have the confidence in ourselves, in our own people. Yes, we may fail, but if we keep trying, we'll get it done. That's one of the things. Because the average Nigerian man will rather, once you just tell him go to India, he will look for the money. You know, it doesn't matter. But if you say, let's go to Lagos and get it done, it's difficult for him.
Feels like Lagos is not good enough for
It's not good enough. Let's go to National Hospital. No, National Hospital, I can't. But if you just say, let's go to India, and be honest with you, they respect us in very many aspects when they meet the professionals from this area as well. And many of the Nigerians who've traveled out, they still go there and then meet Nigerians
that treats them
on ground in that area. You know, that's part of the thing we can do. First, create a self-belief. Then outside that, there should be a deliberate attempt to say, let us put the proper things on ground. Not just providing the equipment, but developing manpower. You know, we are too absorbed in the biggest this, the largest this, the first that. And with the people, look, if you give a Rolls Royce to somebody who can't drive, he can't move the car. It doesn't matter. Do you understand? So if you're going to buy a Rolls Royce, get a driver who's training how to drive it. So we need to develop manpower. Do you understand? Train people. We say, okay, if we train them, then they will leave. They will train more. Soon they will have nowhere to go to.
They'll stay back home.
I mean, they will now have to sit and do the job, and then provide the equipment for people to do the job. We have not yet deliberately start to solve that kind of problems. You know, we still, we just cough, we hold on, we jump, we're just staggering, you know. There should be a deliberate, and it's possible. If there's no big deal about it. It doesn't take any rocket science. We can get these things done if we put our mind to it.
Well, thank God for people like you that would continue to encourage anyways, that people don't leave, but stay to make sure that we build and we make sure that the country is where it is and where it's supposed to be. Well, I'd like us to discuss the International Day for Radiologists and the theme, caring for the patient. But that will be when we come back from this short break. We're going to talk in depth on it and how this is also contributing to the health sector. Well, we're going to go on a short break, and when we return, our discussion will continue. Do stay with us.
Following the sudden outbreak of cholera in some parts of the Federal Capital Territory, significant number of cases have been tested positive for cholera. The Health and Human Services Secretariat has intensified surveillance in the affected communities around the area council. Therefore, residents are requested to report any case of diarrhea to the nearest health facility or the Department of Public Health on the following numbers: Dr. Sadiq Abdurrahman, 0803-705-1784, or Dr. Doris John, 0803-315-6560. Ensure that the water used for domestic purpose is clean, boiled and filtered. Start ORS immediately you have diarrhea. Ensure that all food is properly cleaned and well cooked before consumption. Ensure that fecal waste are hygienically disposed of. Do not defecate in the open or into streams. Houses with surface wells should make sure they are covered all the time. Public Health Department, FCT Health and Human Services Secretariat. Announcer.
Welcome back. Thank you for staying with us. So before we went on the break, we've been discussing interventional radiology, and Dr. Wellington has told us so many things that can be done and so many in treating people through radiology. Before we went on the break, I said we're going to talk about the International Day for Radiologists with the theme active care for the patient. So Dr. Wellington, I'd like us to tell us more about this theme, active care for the patient. Has care been passive, or what does it say, or what's the essence of the theme?
It's, in a way, you say an active care. That's a deliberate care, a planned care for the patient. Do you understand? Now, it brings to fore what interventional radiology itself is all about. Deliberately deciding, taking a decision to do something that's going to solve a problem. Do you understand? So it's when you have somebody who, for example, has a thrombus in a vessel, and it's a planned thing. When you have people, you watch a lot of movies, you have people, and you want to go and do a rescue mission for people who have been, you know how it is. That is a deliberate, active, planned thing. So that's the general idea of the package of an interventional radiology. Do you understand? It is a deliberate, planned, commando care, if you like to use that kind of thing, for the patient. It's not, let's try. You know what you're going to do, and that's what you're going to do.
You know, when you said commando care, it gave me this kind of army kind of thing. And radiologists are called the unsung heroes. Why?
Well, first of all, you know, people like to be surgeons, gynecologists. Those are sweet the ears, and then the public are very familiar with all the stuff. So if you enter into a hospital, you're very likely going to see one of those people on the corridor. Oh, this guy operated. It's not the same thing as a radiologist who is nearly always locked behind closed doors.
In fact, I was going to ask him about that.
Locked behind closed door. Then all the doors around him, there's a warning. radiation area. Do not pass. They understand? And then when you see people go in and out, they're either wearing something. So when you come to the hospital, first of all, you want to avoid
Radiologists.
you don't even know whether they are walking. You don't even know whether they're doing anything. You understand? So I will think that may be why the perspective is, but it's not a wrong perspective at all. It's not a wrong thinking if people say that kind of thing.
Now, you said something about when they're closed in their closets and there's almost everywhere, stay away, radiation. And radiation actually has its side effects.
Yes, it does.
Yes. And for radiologists, I would say that is also an occupational hazard.
Oh, definitely.
But how are radiologists able to manage this? Take, for example, you're a radiologist for 15, 20, 35 years, and you're almost every day exposed to radiation. How do you guard yourself against this?
Let me say, first, it's a choice. I mean, somebody has to do the job, and the job needs to get done. That's one. But secondly, there are deliberate procedures that are laid down to provide safety. You understand? You wear lead jackets, lead aprons to provide vital areas of the body. There are dosimeters you wear that you regularly send for check to see how much radiation has this person consumed over this period of time. You know, when it is above what, there's an amount of radiation that's prescribed that you can say, okay, this person can take this amount of radiation in 1 year. And so when you do all this measurement and it exceeds that time, you take off the person off work for a period of time. Do you understand? So there are several other safety measures. There are equipment, goggles for the eye, something to wear on the neck, on the scrotal areas, gloves for the hands, when you have to do radiological procedures. So there are actually scientific safety measures that are put down to ensure that we who practice in the department are not unnecessarily exposed to radiation, you understand, and for the safety of the job. But like I told you, the job must get done.
That is truly commando, because it's almost like laying down your life for it.
Oh, but the soldier man goes to war. He knows he's going to die. He could die there. But I mean, somebody must defend the country.
Somebody has to be there. Yeah, somebody
so
has to be there.
Be
So I think that's now gives the explanation to why the radiology department is always at the back of the hospital, you know, almost behind every department, and you have to go through this corner and corner before you get to radiology.
Yeah.
Well, so now talking about there's this thing I wanted to talk about when women, not cysts, fibroid. Good. Have there been any interventions in having to be able to deal with fibroid now without having to go under the knife?
Yes.
Oh.
No, yes, that's true.
So tell us more about it.
I've actually mentioned it when I told you that. First of all, what is the problem that fibroid presents? Where the problem it presents, you try to deal with. Do you understand? Okay. Where the problem it presents to some group of women is excessive bleeding.
Oh.
Where their periods are flowing for several days and large quantities per day that can, on some occasions, warrant the woman to have blood transfusion because she's having menstrual period. Then you can locate the arteries that supply blood to that uterus, because the bleeding comes from the uterus. And then you can introduce a foam or a gel inside that place and block the artery from receiving blood to go outside. So that way you have embolized the vessel supplying it, and so if it doesn't get blood, you can't give out blood. You don't give what you don't have. So it doesn't receive blood, you can't give out blood. So the bleeding stops. You understand? So that's one way that interventional radiology is helpful in the treatment of uterine fibroid.
And now, as a radiologist, what would you have Nigerians know or be educated about when it comes to interventional radiology?
I like them to know that it's available. I like them to know that it is not rocket science. I like them to know that there are several personnel that have the skills to effectively deploy for management of cases in several disease conditions. So it's not something that is scarce. Understand? Let them just accept that it's possible, and it is truly very possible. I like them to use the skills that are available to Nigerians and Nigeria and the doctors who are in the country. You know, it's the idea of having the fun or thinking that take a jet outside the country is the treatment of the disease they have, rather than making themselves available in this country. And see, let me tell you, many of the people who live here to have treatment outside, many, I haven't said all, actually have war stories when they go out. Eventually they don't tell you. They like to say, oh, I traveled to this one, had this one. But when they come back, the follow-up of this patient falls back on the doctors in Nigeria. And the mismanagement, if there is, in all these cases, falls back on us. Because it's not just having to do something, you need to maintain that thing. You understand? And so we find out that for something they could easily have done here, they just go mess up a lot of things and all that stuff. So, yes,
So you said something, and it has been one of the major issues in the health sector. The fact that if someone has an issue, they say you have to travel. Most times, people don't have the money. And you see people having to do out-of-pocket expenses for their health. And that has been a major, major issue, and we have lost quite a number of people due to that. And there is always this debate of what should be done or how can it be done to make sure that citizens don't necessarily have to spend out-of-pocket for health. And we talk about health insurance. And it seems like we've still not been able to get it right. But what can we do, or what can be done, or what should be done to make sure that this is actually addressed, and at least quite a number of Nigerians would be able to, without having to spend out of pocket, access healthcare?
Lois, there's no big deal. There's not any problem around us that the solutions are not available. I don't really know whether we don't want to, or, I mean, I really don't know why, but the answers are right. You already mentioned this. Health insurance. So very easy. I'm enrolled, I registered for it. I have never used mine. Well, we are 10, 15 people. We are making contribution. Of the 10, 15 people, nobody may fall sick, maybe only one in 1 year. You can use the money we are contributing to treat the person. So what we need to do is to bring in more people into the fold. So the contribution becomes large. And so the ease with which to solve problems for the few who fall sick is easy. I don't think that's any rocket science. Do you understand? If you go find out, the amount of money available within the health insurance is humongous. Register more people, put them inside the health insurance system. You know, but why we deliberately set up bottlenecks to, for example, they create HMOs, and then HMOs find it difficult to, for example, pay the hospitals. I don't know. And then you find that hospitals who ordinarily will do a scan, let me say, a scan for, say, 3,000 naira. NHIS will deliberately say, you can only do it for 1.5. Do you understand? Do you think the hospital will be encouraged to want to do a scan for the patient using the NHIS? I don't know if you understand me. No, they will prefer that. I mean, if you pay out of pocket for 3,000 naira, then why should I now be waiting to be paid 1,500 naira. Because before the hospital gets its money, eventually for the HMO, it spends time, it employs people to go through papers, you know, there's waiting, your money has been invested, you need to buy the things to do the procedure. So you will expect that if I can do an ultrasound for 3,000 naira for a patient, and you want to do it, let me use the word, on credit as it is in a health insurance service system to pay later, then you should pay a little bit more for that service. That encourages more health providers to go into it and actually make people use it. Look, I can tell you that even if you have a health insurance system going on, the way it is now, you will get to some hospitals you want it to. They will tell you, if you want to pay, this is how much you're going to pay for it. But NHIS does not cover this.
So you wonder, what does NHIS cover?
Then you're wondering, but NHIS can actually cover it if you give it right pricing. You understand? That is on one aspect. Enroll more people. You know, it is not only government workers who fall sick. There are people who are around, who are doing the various businesses. I've met somebody who said, I'm 35 years, I've had this done, I've had this done, I've had this done, but I have never paid out of pocket for my health in my country. I mean, what's the big deal? I mean, it's not hard at all. But you will see us, we want to buy jet for the, want to buy SUVs. I mean, the purpose of the money is to provide health care, not to provide comfort for individuals. You know, buy large, several cars. It's not going to make a patient get better. That you have long convoy of vehicles as executive director of whatever director of NHS or anything. It's not going to make health better. You understand? Provide that money for people to get well. That's primarily your job. And I'm sure that even if you don't take a penny for NHIS for your transportation, you are, to get to that position, you are able to buy yourself a vehicle that can take you around, for the number of years you want to live, if you want to. You understand? So I'm saying, basically, it is no big deal. We can solve this problem. If we enroll more people, if we're deliberate in enrolling more people, if we're deliberate in pricing the system very well, and stop trying to think that things must be hard for that thing to be valued. That's a mentality. I mean, things must be hard for people, for them to appreciate it. There are some things we're going through that people don't think about anymore in some ward. You know, it's sad anyway, but sad. We're on the road anyway.
We're on the road, and just like you said, even though we are no longer where we used to be, we're still not where we're going, but we're on the road, and hopefully we will get there. Well, thank you very much, Dr. Wellington, for taking our time to be here with us on health and well-being. And it was a pleasure being here with you, enlightening us on so many things. Thank you very much for taking out your time. Well, I'd like you to just give a word of advice or a call to the government on what can be done better to see that things are actually made better, and a call to the audience before we wrap up on the program.
Because I'm on a program on the TV, I have to say something to the government. Otherwise, there is really very little that the government doesn't know. You understand? What I'll just be able to say to them is to act on it. They should talk less and work more. You understand? That's what I'll just be able to tell them. They do have the wherewithal. The wherewithal is there. It's government institutions are provided with everything they need. Research department, all the departments are there. You know, they should just simply dust the book, stop talking, and do the job.
Well, thank you very much, Dr. Wellington. We appreciate your presence here.
It's my pleasure.
Well, that's the size of our package today on the program Health and Wellbeing. Do remember to keep it a date with us same time next week. I am Lois Apasambo. Do stay safe.